Let's see. Okay, well, we want to welcome you to this this gathering, which came out of, I wanted Melody to do the introductions because she is so integral. She and Lucy have been so involved in bringing this together, and it came out of a series of trainings that we did in the spring that were more broadly dedicated to telebehavioral health training among community-based providers in the state of Washington. And Lucy, with her role and connection, said, you know, gosh, it would be so nice if we could do something like this that was specifically aimed at Indian healthcare providers. And so that's how this all came about. And it's turned into this really wonderful gathering of people who are willing to share their experiences and expertise. And so, so thank you to all of the panelists and presenters for being willing to join us today. And thank you to all of you who have joined us to listen in and participate in this. So today we're going to be talking about addressing barriers and highlighting innovations in telebehavioral health. You can go to the next slide, please. And just a little background on the Behavioral Health Institute at Harborview Medical Center at UW-Medicine and the Training Workforce and Policy Innovation Center. The BHI is a center of excellence where innovation, research, and clinical practice come together to improve mental health and addiction treatment. The BHI established initial priority programs, which include improving care for youth and young adults with early psychosis, behavioral health urgent care walk-in clinic, and the last two we are focusing in on today, expanded digital and telehealth services and behavioral health training workforce and policy innovation center. Next slide, please. And I want to introduce all of our wonderful folks today. So we have Dr. Chris Four, who is currently the director of the Indian Health Service Telebehavioral Health Center of Excellence. He's a member of the Choctaw Nation of Oklahoma. He received his doctorate in child clinical psychology from Oklahoma State University. In 2009, he established the IHS Telebehavioral Health Center of Excellence, and the mandate for the center is to explore the feasibility of telebehavioral health within IHS regionally and nationally, improve access to care, develop models of care, and to address sustainability. We have wonderful Lucy Mendoza and Michael Longnecker from the Washington Healthcare Authority, who all of you I'm sure know, and we'll be talking specifically about billing and reimbursement with telehealth today. We have Dr. Megan Ballou, who is Cherokee and is a clinical psychologist originally from Oklahoma. She's the current director of behavioral health for the Lummi Nation in Northwest Washington. Catherine Akia, who is a consultant for the American Indian Health Commission, works primarily on Medicaid transformation projects in the tribal behavioral health system. Her experience includes over 17 years of social justice work in public health, the justice system, and labor organizing. And we also have Jen Olson, who's worked with Washington tribes for over 20 years on population-based public health programs. She is also a consultant on Medicaid transformation projects with the American Indian Health Commission. We have Melissa Hurt-Moran from Camas Path, who currently holds the position of CD Clinical Manager for Kalispell Tribe of Indians. She has held her SUDP/CDP certification since 2005 and currently has SAP and NCAC 11. She has a master's in clinical mental health counseling with a minor in addictions counseling. And last but not least, we have Micah Woodard, who is an LICSW and BCD. I don't actually know what BCD stands for, so you have to inform us when you talk. He's at the Western Oregon Service Unit and serves as the Behavioral Health Director at Indian Health Service at the Western Oregon Service Unit. He's a commander in the U.S. Public Health Service Commission Corps. CDR Woodard has served in this role for over 10 years, providing comprehensive school-based health services, integrated behavioral health, and program development and planning. I think I got everyone. So next slide, please. And then I'll turn it over to Christina to talk about the Northwest MHTTC, who has partnered with us to deliver this program today.
Great, thank you so much. We are very, very honored to be here and just wanted to share a little bit about the Northwest MHTTC. My name is Christina. I'm one of the co-directors, and we are a relatively new, 2 years in, resource for the Northwest and Region 10. And so we disseminate evidence-based practices, implement other promising and best practices from other communities for serious mental health issues into our field. We work with a variety of parts of the field, so behavioral health, primary care providers, school, tribes, and a variety of other settings. Next slide. The MHTTC is a network actually across the nation, and some of you may have heard of the Addiction Technology Transfer Centers in your work, so they've been going for a lot longer than we have. But our point is to disseminate resources and free training across the nation and across the region. Next slide. Our particular Northwest MHTTC does have a website. We have things like live webinars such as this. We have online courses, research and practice briefs. We have a resource library on our site, and we have archived webinars as well. Next slide. If you'd like to keep in touch, we can put these things in the chat later, but we do have a monthly newsletter and we share things like this event, and you can email us with any questions. We have some social media as well, so we'd love to hear from you. And now we'll go to the next slide. We always want to be mindful about using language that promotes recovery and is culturally appropriate, and just also want to remind folks that this webinar is being recorded, so we just want to make sure we aren't disclosing identifying details, but we just know that this is a network slide that came up recently, and so we just want to be sure to remind everyone what our goals are in these kind of events. But now we have a few logistics regarding communication during the session. Next slide. So we'll review quickly in the next couple of slides how the webinar is set up and how you can use the chat and Q&A to communicate with us and what works and how to do that. So first, in the next slide, we have the chat box. And so you're all using that, I think, have been using that. And I'm sorry, there we go. Sorry, next slide. The chat box. So our team and the rest of the panelists may share information about logistics. Let us know if you're having tech issues. You can share with us, but it isn't a huge visible thing that we want all the questions coming to. So we'll go to the next slide because we want to make sure we do get to your questions. And so you can either type a question into the Q&A window, and someone might type a response back to you, or they might call on you later to discuss in the discussion portion, or you could raise your hand, and that will also alert everyone, and then they can unmute you later if we want to do more audio discussion. Next slide. Lastly, your feedback is really important, and so like any training center that receives funds, our funders want to see what we're doing, but more importantly, we want to know how we're doing and if we're meeting your needs, and so we greatly appreciate your feedback. Next slide. After today's session and near the tail end, we'll be putting in a link. And so it's a very short survey just to tell us how did it go. We'd love to feed that back to the presenters and the panelists and all the organizers, and it just helps us really plan future sessions. Just a reminder, slides, this recording, and resources will be posted, but we do not have the ability to use certificates or CEUs for this series. Next slide. All right, so now I'll turn it over.
Can I jump in really quick before Dr. Ford gets started? I forgot I was going to run a poll after I did the introductions of all of you. I was going to ask our attendees to tell us who they are. So if you wouldn't mind, I'm going to run a poll and ask you all to click on who you are, and then we'll share the results with the group so that our speakers know who they're speaking to today. Looks like right now we have about half of the folks have voted, and if you do mark other, please feel free to put into the chat what you are, if you're not an administrator, clinician, behavioral health clinician, or prescribing clinician. And I'll give it just a few more seconds. great. We've got a telehealth program specialist. That's wonderful. And a care coordinator at an MCO. And I'll go ahead and end the polling now and share the results with you. And as you can see, we have an equal number of administrators and other, an EHR coordinator. And we have the next largest group is 23% are behavioral health clinicians. We have a couple of prescribing clinicians and one other clinician who maybe is not a prescriber. So I will stop sharing the results. If that box stays up on your screen, you just go up to the upper right hand corner and click on the X to get it out of your way. All right, and I'll turn it over to Dr. Four. Thanks.
All right, thank you everyone. I appreciate this opportunity today. I was looking through the attendees and see a few familiar names in chat, so it's good to talk with some folks I haven't touched base with in a while. And today I'm going to be talking just very briefly about some of the things you need to be paying attention to if you want to do telebehavioral health within Indian country. I'll be doing a much more in-depth talk on this next week. It'll be a really deep dive, but this is a pretty cursory overview. And I will apologize up front. I put October 17th instead of September. I'm just wishful thinking that we could get past 2020 and hopefully 2021 would be better. But so sorry for that typo there. Next slide, please. So one of the things you all need to be familiar with if you are not already, and hopefully you are, so I'm not going to spend a lot of time on this, with the public health emergency, there have been lots of changes and waivers and dispensations given to try to bolster telehealth overall, and telebehavioral health also gets some benefits from this. So one thing to be aware of, this is all ending October 24th, I believe, right now. And it's not clear which of these, if any of them, may stay. So that is something we had a call with CMS yesterday around this, and so it's something a lot of people are asking questions about. First one here, same state's licensure is no longer required. So that is a big deal. For you that run tribal programs or IHS programs, this isn't a big deal because you've had this. Hopefully you know that. Your providers that you use don't have to be licensed in the state where the patient is, which is great. This is really a big deal for our urban partners and for private sector. Again, we'll have to see if this sticks around after October, but currently no one doing telehealth has to have a provider licensed in the same state as the patient. The next one, HIPAA requirements are currently relaxed regarding our televideo platforms. Basically, they have said you can use almost anything that's not a group platform. A group platform would be something like Twitch, for example, where it's more of a broadcast platform. Facebook Messenger works, FaceTime works, Google Hangout works. All that, HIPAA is saying, yeah, go ahead, as long as you act in good faith is the terms that they use. So as long as you're not purposely trying to share information, you can meet with your patients on almost any video platform that you can imagine, which is great. It's really opened it up a lot. Next slide, please. CMS and some billing, and I know we'll have some billing folks on board, and we'll be talking a little bit later, but some telephone contacts are now billable. That's something that's not generally a billable service, but some virtual check-ins that you can do. There are very specific examples around what those are, so I'm not going to get off into the weeds, but just be aware that some of your telephone visits may be billable. And lastly, the four walls rule has been sort of waived in that in-home services are now can be reimbursed. It's a big change and very helpful for us. A lot of our patients aren't traveling. A lot of our clinics aren't necessarily open. And so being able to see the patient in their home or now in an alternative setting and still get reimbursed is really great and very helpful. Next slide. So when we talk about telehealth overall and telebehavioral health specifically, I'm going to add some stuff to this slide that as I was thinking about it a little bit later, I probably should have put in there. Telehealth, the reason you use telehealth, the primary reason is to provide access to care. That's really what telehealth is all about. Getting services in places and to people who would not otherwise have those services. That's really the strength of telehealth. I would also say that there's a potential secondary reason to use telehealth, which is to increase quality of care. If you can get some highly trained providers, some providers who are maybe very culturally competent or culturally aware, and match them up with the right set of patients, that's another really good reason why to use telehealth. The other thing you want to look at whenever you are thinking about telehealth and telebehavioral health specifically is, what are your community needs? One of the things that I often talk to people about is that telehealth generally isn't here to replace a service. That's not, in my opinion, especially in Indian country, there's plenty of work to go around. So I think telehealth is often here and is most productive in Indian country when it plugs gaps. When you have a service that you want and need but can't get it any other way. So we're not talking about replacing your behavioral health program with telebehavioral health. We're talking about getting you maybe an addiction psychiatrist a day, every other week, because that's a service that you need. You don't have the workload to hire someone. You don't have the money to hire someone full-time, and you don't have that need, but you really need that service a day a week or a day every other week. Tele is great for that. If you want to run your whole program via tele, you can do that, but that gets a lot more complicated, and that's really not, in my opinion, where the strengths of tele lie. So when we talk about telehealth and telebehavioral health specifically, with all these new things that have come around and us having to pivot very quickly into seeing patients outside of clinics, I developed these scenarios, and this is, you need to be thinking about this whenever you're going to deploy telehealth and telebehavioral health specifically. Because there's lots of different permutations here that impact how things are going to look. So first of all, where is your provider going to be and where's the patient going to be? Those are really the key issues. Clinic to clinic in our system, in the IHS system, is what used to be our most common model. That has now changed, but it's also the easiest to control. The provider is in an IHS facility, the patient's in an IHS facility, or maybe a tribal facility, and they connect. That's pretty straightforward. Let's say though that's not how it's going to happen now. Maybe your provider needs to be at home to self-quarantine, for example. So they're connecting from the home, and you've got the patient in the clinic. Gets a little more complicated trying to negotiate access to the EHR, for example, firewalls that may be in place. Let's take the third example here. Now you've got the provider in the clinic, but now the patient's at home, again, for various reasons. Maybe they need to care for someone. Maybe their car broke down. Multiple reasons why that may happen. Again, that can be very challenging. One of the things that has really become very, very clear to me is the breadth and unfortunately depth of the digital divide in this country. I was certainly aware of it. I've been doing this for almost 12 years. I've known it's out there, but this has really been brought home during the pandemic of the lack of connectivity in Indian country. So that gets very challenging. And then the last one here, which is our most challenging scenario, but the one that we're dealing with quite a lot now, you got the provider at home, the patient at home, and how do you make that connection work through all of the open internet, access to the HR, the connections, the scheduling. It gets quite complicated. So just be thinking about this if you're planning telehealth or needing to pivot to a different one of these scenarios. There are lots of different things that you need to be aware of for each of these. Next slide, please. So at the broadest level, here are some of your considerations I just want you to think about if you're going to be deploying telehealth. Very basically, what's your platform and your equipment? As I just said, this has kind of gone away to a large extent here lately with the relaxation of HIPAA. You pick up your iPhone, they pick up their iPhone, and you're good. In theory, anyway, assuming connectivity, which is our second one, but there doesn't have to be the investment that there used to be in telehealth as far as equipment goes. Now, we don't know if that's going to stay around. So what I would encourage you to do, if you're using platforms that aren't HIPAA compliant, which is you're well within your right, it's at least for the next 5 or 6 weeks, be thinking about what you're going to do afterwards. Because I'm really concerned that a lot of our programs are going to be left sort of high and dry with no HIPAA compliant way to provide the same kinds of care. Yes, there are platforms out there that are HIPAA compliant. Yes, they usually cost money. and they're maybe not as user-friendly as you've been used to, but you should be thinking about those if you're planning on keeping telehealth. I could be wrong, and that they waive HIPAA or keep the loosened regulations in place for this, but it's something to be aware of. The other thing just to think about as well is that there was a time when I got into this 12 years ago, it costs a lot. Our standard telehealth unit costs about $15,000. I can get someone connected for the cost of an extra monitor and a webcam. So I don't know, $150 now. So the barrier to entry as far as equipment goes really come down significantly. So don't let that stop you. Just be mindful of it. And again, mostly the platform and whether it's HIPAA compliant. Bandwidth. This is one of the questions we get all the time. How much bandwidth do I need? Unfortunately, it's not that simple. More is always better. So that's the good news. The issue is here, and again, I'll get way more into this in my discussion next week, is that it's not necessarily how much bandwidth you have, it's how much headroom you have in that. So if you've got a pipe that's half full and then you want to do telehealth, that's great because there's lots of room between the water level in that pipe and the top of that pipe. If I've got a really fat pipe, but it is full all day, every day with people doing other things, it doesn't matter how fat the pipe is, it's already all being used. So telehealth would be very challenging. If you have a garden hose, but no one's really using it, you can do telehealth through a very small connection. So bandwidth, the more the better, and it's really about the utilization of the bandwidth that you have and that headroom in there. We'll get into that more, and like I say, next week, but it is something to think about. One of the things that I think people sometimes overlook is how am I going to document care? How's a provider going to document care? It's very important, but it's something that's really easy to overlook. Most of us have electronic health record. If that provider is not in your facility, how do they get access to that electronic health record? Do they have to use a virtual private network, a VPN? That's what happens within the IHS system. Can you give them access to it some other way? So be thinking about that. That can be a showstopper. Also, if you're working with the prescriber, things get quite a bit more complicated in that how are they going to prescribe in your system? Does your electronic health record allow them to prescribe electronically? If so, that's great. What about controlled substances? This is where it gets very complicated for those of you who had to deal with this and the Drug Enforcement Administration, DEA. So basically, it requires a controlled substance, which can be pain meds, which can be meds for ADHD, which can be anti-anxiety medications. They require what they call a wet signature. That means there's no faxing. That means that there's no sort of just prescribing in the regular way, but there's usually at least 2 or 3 factors that have to be to confirm your identity if you're doing it electronically. So controlled substance prescribing can be very challenging. So again, something to be aware of if you're working with the prescriber. Telehealth coordinator. I will beat this drum loud and clear next week. Just mention it here. This is what your program, in my opinion, in my experience, running a program for 12 years, having 26 sites around the country, our success providing telebehavioral health relies on the telehealth coordinator at that clinic. We can have the provider online, we can have everything ready to go, but if that coordinator where that patient is isn't available, doesn't turn on the equipment, doesn't walk the patient into the room, doesn't schedule the patient, doesn't call the patient ahead of time, things kind of fall apart. So really be thinking about this. This is not something that we generally think of as a full-time position for most programs, but it is someone who needs to be totally dedicated when the telehealth clinic is running. They don't need to be doing any other activities. They need to be totally focused on that program. And also, I would say even beyond that program, they need time to coordinate, to call patients and things like that. So they can have other duties, but during that clinic, they have to be really focused. And this can be all sorts of folks. We've had folks that are secretaries do this. We've had nurses do this. We've had counselors do this. This role isn't defined by a profession or by a license. It is really a role that needs to be filled. And it needs to be someone who is consistent, someone who is responsive, and someone who's reliable. So telehealth coordinator is really one of the keys that we talk about a lot. Next slide. I'm going to wrap things up here and be quick about it. You'll need a backup plan and 2 backup plans. So you need a clinical backup plan. The patient says, I'm going to go hurt myself right now. What are you going to do? You need to have a plan for that. We do not deploy to a site until we have a backup plan set up for the clinical side. You also need a technology backup plan. What if your internet fails? What if the audio goes dead? What if the video goes dead? You need to have a technology backup plan. Both of those for us have to be in place before we start services. And then lastly, and you'll hear more about billing later, sustainability. This is great for the short term. We've seen tons of programs pivot to telehealth to meet patients' needs, which is awesome. But is it something you can sustain? I can tell you from what I'm hearing, patients love this by and large. And I'm hearing, well, why can't we do this all the time from patients? I don't want to drive 3 hours for a 20-minute med check with my psychiatrist. I want to stay at home and do that here. It's much more comfortable. I can get the same kind of care, and now I don't have to take my kids out of school or miss work, or I can, still care for my mom. So sustainability needs to be addressed because I think our patients are going to want to keep this up, and perhaps many of our providers will too. With that, I'm going to wrap up my comments, and if there are any questions, please put them in the chat or in the Q&A pod. Thank you, everyone.
Thanks so much, Dr. Fort. Let's go to the next slide, and we'll have Lucy and Michael talk about billing and technical assistance.
I never know if I should wait for Lucy or I should start. Hey, this is Mike Longnecker with Washington State Medicaid. I'm going to go kind of fast because Dr. Ford just said a lot of the information that I'm getting ready to present. That was so cool to listen to. We can go on to the next slide. This is our contact information there. We can see the first email address, tribalaffairs@hca. That's our ticket system. So if you ever want to reach out to any of us on our team, just send a question over to tribalaffairs@hca.gov. Otherwise, there's Jesse Dean, our administrator, myself, claims and billing, Lucilla Mendoza, behavioral health administrator, Lena Nashan is part of Medicaid transformation, Jovita is our administrative assistant, and we've got our 3 liaisons there. We have 1 vacant liaison position right now. Next slide. This is just backup information for later on. My only regret on this slide is I wish I would have said telehealth and telemedicine, because telehealth is the umbrella term. I should have put that word first. But these are the links to our billing guides, the Healthcare Authority COVID website. Tell you, when COVID-19 first started, that COVID website had 1 document on it, maybe 2. If we go look at it today, there's about 97 documents in there. So it's just responding to the pandemic with information. And of course, our billing guides. Quick mention on telemedicine. It's a distinctly defined term in our WAC, but we don't have a WAC definition of telehealth. We'll go on to the next slide. Why is that important? It took me a couple of months working with billing folks to come up with this little bicycle analogy. If we go back a year, say it's a year ago and COVID didn't even start yet, we were allowed to ride bicycles. Telemedicine. Telemedicine is a bicycle. So we were only allowed to ride bicycles. Phone calls are out of scope. Yes, doctors could have done phone calls a year ago, but we'll set that out of scope. So bicycles were the only tool that we were allowed to ride. The pandemic started, and as Dr. Force said, the other forms of telehealth opened up, and we were allowed to use Skype, which is the tricycle. We're allowed to use phone calls, which is the unicycle. The important part about this slide, and when it comes to billing, is only that thing with 2 wheels can be called a bicycle. Why is that so important? We're going to look at Zoom really quick. If we're using HIPAA compliant Zoom, it meets the definition of HIPAA compliance, then it is telemedicine. If we're using the Zoom version that is not HIPAA compliant, that is the tricycle. We are allowed to ride the tricycle during the pandemic. So I was just trying to get that point across. We can use all the tools that we need to during the pandemic, but only a bicycle is a bicycle and only a phone call is a phone call. Why is that so important? We're going to briefly go to the next couple of slides. This is billing down in the weeds. Billing folks, feel free to reach out to me at any time. I always sort things by category. This first slide is for medical, or excuse me, telemedicine. We've got medical, dental, mental health, and SUD, how you bill it, the coding, the modifiers, and the references. We'll go on to the next slide. And this next slide is telehealth, which is other forms other than telemedicine. And you can see I did the same thing: medical, dental, mental health, and SUD, the references and how you bill. When it comes to billing, I tell you, for most folks, I am going to say reach out to me, because to try and make a slide that would address for Washington all 29 tribes and have the slide actually work, it's really difficult. There's a lot of one-on-one communication that I do every day. And I think that's the last slide.
Thanks very much, Michael. I appreciate the information. As I noted in the chat, we're holding all questions until the end when Catherine and Jen are going to facilitate a discussion. So if you have any questions, please feel free to type them into the Q&A section, and then we'll address them. Or if you want to ask a question out loud, you can raise your hand and we would call on you during that discussion. But right now we'll move on to Dr. Megan Ballou, if she could do her presentation.
Hi, thank you. Hi, everybody. And I kind of agree with Michael. I think there's going to be a lot of repeated themes here, because some of the things that Dr. Ford touched on definitely are consistent with what we've experienced here. So my name is Megan Ballou. I'm from Cherokee Nation, but I'm currently the Director of Behavioral Health for Lummi Nation in Washington. So I'm going to talk a little bit about our experience at the beginning of COVID, what's worked, what our continuing barriers are. So next slide. So this is just an overview of kind of across the tribe what the experience with COVID was. So our very first case here in this community occurred on March 12th, our first confirmed case. And you can see that that following day the school was closed. Several days later, casino closed. A shelter-in-place order went into place on the 22nd. And so kind of consistent with that graph, you know, our numbers kind of went up quickly. We had a very proactive collaboration between leadership and our public health team to really try to, you know, flatten the curve at that point, with a couple of other peaks, one occurring again in April, and then another little peak occurring not that long ago in July. And when the slide was made about a month ago, there were 59 cases. We actually had one new positive case this week, but for the most part, these really proactive measures have really helped lessen the benefit or the impact in the community. Next slide. So just to kind of overlay how that impacted our behavioral health services during that same timeline. So March 11th, Lummi leadership actually announced an early release kind of at the last minute, and it was seen as a test to see how prepared we were for an emergency, anticipating that at some point in the future COVID might impact the community. So staff was asked, you have about 2 hours, take anything you need to work from home, and let's just see how this works. The very following day, we had our first positive case, and most people never across the tribe never returned to the office. So it just happened that, you know, that kind of happened in that order. That day, that next day, behavioral health leadership met, tried to quickly brainstorm, you know, how are we going to make these changes so quickly. We bought 25 professional Zoom accounts that day, luckily, because I think the fall count purchases. So we got right in there in time to get those processed within a few hours. That weekend, one of our staff members tested positive for COVID, which really highlighted the need for us to move quickly to telebehavioral health, because all the clients that person had come in contact with that week, and multiple staff had to be quarantined that following week. Luckily, everyone's health improved and wasn't impacted, but it definitely showed us that we needed to do that quickly. So that following week, the 21st, all mental health counselors had their Zoom accounts. They all individually called the patients they had, their clients on their caseloads, talked about what was happening, kind of gave each patient, each client the time to ask questions, to think about those options and to offer those services. And I do think that was a key in us maintaining that personal relationship, to have each clinician talk individually at that point with their clients. Okay, next slide. Just a really quick overview of what our behavioral health staffing looks like at this point. So we have administrative staff. It's kind of silly to break it up in this way because we're all one team, but we do have quite a few mental health clinicians, crisis outreach clinicians, and then some grant staff, but everybody works together. So really a combination of counselors that are doing individual and group sessions, and also some just community education on stress, as well as people that are really out still in the community doing outreach and education. Okay, next slide. I'm really impressed by these numbers. And I think it really speaks to that personal connection, being able to continue to have our clinicians talk individually with their clients. At the first two columns, it looks at our 2019 count and our 2020 session count. And as I said earlier, it was mid-March when we made that switch, and we have not seen a dip in our client numbers. So we actually have a lower no-show rate now, which I think a lot of people, it sounds like, maybe are experiencing. And we have had an increase requests for services. I think that's a combination of, again, that personal connection, and also a lot of really good social media and communication about what we have to offer and how to access our care. Okay, next slide. And so making sure that we always have those backups. There's plenty of times when, for whatever reason, on one end or the other, and reaching a lot of people. It was really an initial challenge figuring out how to do all of our paperwork that had always been, signatures, pens on paper, and doing that remotely. And so purchasing a digital signature program to be able to get ROIs and consents and things like that signed and put into the chart was a challenge, but I think one that isn't perfect, but we've worked out a lot of those problems. Being able to provide clients with the appropriate technology. There were many people, clinicians as well as clients, that did not have a device that was working in their area with the capability to participate in Zoom. So in Washington, we were really lucky that the Healthcare Authority was able to provide a lot of free iPhones that were no cost to the client, no cost to the tribe. We distributed around 100 of those to clients that did not have smartphones or smart devices. And that really, we were able to do that pretty quickly. And that definitely was a huge part of us being able to continue to provide those services. As I mentioned, we have a lot of our staff that really took on the strong social media presence. So putting out lots of information about coping, about wellness. They do daily mental health videos that also include how to access service, but we've had a really positive response in the community about even people who aren't necessarily accessing our counseling services, but just being able to get the health and wellness information out to as many people as possible. One thing that we have heard from actually quite a few clients is that the stigma that they felt having to walk in our front door was removed. And so that's part of the show rate. That's part of some people accessing mental health care for the first time that for whatever reason, didn't feel comfortable walking through our doors, but they feel comfortable accessing that care from the privacy of their homes. And so that's been definitely a positive. And then I think I just don't want to, leave out the importance of taking care of ourselves and each other. So making sure that we maintain staff check-ins multiple times a week. So we have our Zoom meetings multiple times a week with the full staff, mental health staff, to problem solve as quickly as possible any barriers that we might have, and just check in on each other, support each other. Okay, next slide. So what barriers still exist? Again, just poor internet, Wi-Fi, cellular connection. So one of the things that we were able to do, in addition to providing some smart devices, we established outside of our medical clinic what we call an iPad visit. So if there's just no way for a client to connect to their counselor or their medical provider in the location that they are currently, like their home or their office, clients can actually pull their car into a semi-private space outside of our medical clinic. Someone takes out an iPad and they can conduct those Zoom calls in that setting. That ties in actually 2 points down to privacy. Barriers definitely exist with privacy. So I just had someone talking about this yesterday. So someone who is able to access their clinician from their home, but they have no privacy within their home. So part of what they want to talk about is obviously some very confidential private information, but they have nowhere within their home to discuss that without their entire family being able to hear those things. So trying to figure out how to provide people with that private space and that confidential space is still a challenge, and we're trying to think about ways to work around that. And that really ties into services with youth. I think our youth have an added layer. One, they might not even have a device, so they are having to ask, let's say, for example, a teenager, they're having to ask their parents to use their smartphone to participate in the session. And then some of what they want to talk about, for example, may not be something they're wanting to share with their parents, and they don't have the ability to drive somewhere else to have that call. So we're really looking for ways to continue to outreach with youth and provide them a private space to have those services. And then I think it's just hard on all of us, right, to feel that isolation, adjusting to home offices. So a lot of focus on counselor wellness. So we're taking care of ourselves so we can better take care of others. So we've done things like have our physical therapist join some of our staff meetings to talk about how to best set up a home office, so that telehealth doesn't necessarily have that negative impact on our counselors. Okay, next slide. Oh, that's it, sorry.
Great, thank you. Thanks for touching on that, Megan, about the taking care of yourselves as you're taking care of other people. I think that has really arisen as an issue during this period. So thank you for that. I think before we go to the discussion, we have Melissa and Micah who didn't have slides, but we wanted to give them the opportunity to talk a little bit about their programs. So let's ask Melissa first if she'd like to give us an overview of what she's doing.
Yes, can everybody hear me okay?
Yes, we can.
Excellent, that's always a good thing with tele anything nowadays. So I work for Camas Path, and we provide substance abuse treatment services, mental health treatment services, gambling treatment services, and then we also manage the crisis services for the tribe. So we were in a similar situation as I think everybody across the state. We made the transition to telehealth in 13 hours, and we didn't have any equipment. We still utilize desktops because of the cost. Laptops are significantly more expensive than desktops. We didn't have webcams. You couldn't get webcams from Amazon or anyone. And so we had to kind of hit the ground running and figure out how to do it. And we were able to come together as a team. We utilized our personal equipment at home, and our IT staff came out and set it up to increase the confidentiality as best as they could and the protections needed. We definitely have hit a lot of challenges. It's wonderful that Medicaid has really assisted in making this process smoother for reimbursement. We have not encountered the same process with private insurance companies. So we meet a lot of challenges with reimbursement through the for the teleservices through them at this time. And so that's something that we're consistently working on and communicating with those representatives from like Blue Cross to address that. It's definitely more staff intensive. Our need for crisis interventions increased. We went from a total of 4 individuals on crisis plans to 27 in the month of April. We do not have a high COVID caseload. The tribe has only had 4 individuals that tested positive for COVID, so we've been very fortunate for that. But the technology limitations on the reservations is extreme. The access to services, we were able to get iPhones from HCA as well, but they don't have signal. So they have a cell phone, but they can't utilize it. And transportation to where Wi-Fi services are available publicly is also a barrier, because transportation is not readily available in the communities. And so it's just, there has been a lot of challenges for individuals accessing care, and not every solution is working for every client. And so we're just consistently needing to work together to find a new solution for a new problem. We definitely have noticed a drop of increase in substance abuse groups. People don't feel that same connection to their group members that they do in person. And so we've recently started some dialogue sessions with our clients on how can we work to build that connection in the group setting through the telemodel that they're used to having by being in person. That's everything for me.
Oh, thanks so much, Melissa. Boy, it sounds like some common themes are developing here. Let's turn it over to Micah to see what he has to say about what he's been doing.
Greetings, everyone. Hope everyone can hear me okay. We're actually located in Salem, Oregon. We're a unique site. We're a certified school-based health center in the state of Oregon. We serve comprehensive school-based healthcare services and fully integrated behavioral health services, serving the Chemawa Indian High School, which serves youth coming from all over the country, 70 or more tribes in a typical year, representing 20 or more different states. There's always been challenges, and Dr. Ford has been an exceptional resource for us over the years. And for students that, let's say, leave at the end of the school year, and care transition planning and how to best coordinate and navigate complex care issues, such as we have a youth that we made referral for residential treatment, and their treatment is done, let's say, in July when all the students have left, and you have care coordination planning issues because there's no appropriate step-down treatment in their local community. So we've kind of been navigating, at least the 10 years I've been here, some of the complexities around complex care. In the last couple of years, we've also added integrated behavioral whole health and adding integrated LCSWs and psychiatric nurse practitioners within our medical home model. And so we've been adding more telebehavioral health services, more traditional services just in general. And we've kind of used the care coordination type services over the years in terms of summer for students that, let's say, would leave and we know they're planning on returning. As it relates to COVID, because our students had to leave abruptly in March at the earliest signs that this could be disruptive, we really sped up our care transition process and resource connections with tribal home communities. And we did some things that we normally would not do at the end of the school year. We met with all the students and just did some really strong outreach, mental health promotion, and followed it up with a comprehensive needs assessment survey that we used our partnership with the school to get out to the students, and then also provided a comprehensive list of web-based resources and supports. And that kind of got us thinking about, and then part of that led to us For those that have been active in treatment, having that disruption, creating a bridge continuity for telebehavioral health over the summer. But I think the bigger thing for us is it really got us thinking about we need to be more intentional on how we use technology to enhance the level of quality and access of the services we provide. And so part of this, let's say some of the partnerships with Indian Health Board and We Are Native and other things out there, but really rethinking how we use telebehavioral health services instead of just through the conventional treatment lens, looking at it through a comprehensive continuum of care lens. And so that's kind of reshaped our approach this year, because for our school-based youth, right now, there's no plans for them to return on site on campus. So some of the things that we've done is we're developing plans of how we can create like promotion videos, getting more information resources out there. We've assigned a cultural community care coordinator that's starting, has school applications as the students are doing distance learning, a mapping where all our kids are coming from, and start mapping a comprehensive what resources are available in their community, coordinating with the school-based counselors so we can really step up our care coordination game. So for example, if we have a provider that was the primary counselor last year, but due to the needs of that student, it may not be appropriate for that clinical care being provided via telebehavioral health, versus that provider might be better positioned to try to get them connected with a local therapist or local resources and support it more as a system of care coordination, continuity care support. So we've been really kind of challenging kind of some of our paradigms. We reached out to all the behavioral health consultants as part of this effort of building a database to start mapping all the different, from social services, food resources, shelter, behavioral health, start like a community resource database, and try to form a broader collaborative so we can, moving forward, be a lot more responsive in terms of how we can optimize the system of care through technology. And we're fortunate too, we had an existing collaborative with the AIMS Center at University of Washington as part of our integrated behavioral health, and a collaborative grant we did with George Fox, which had specific things they were going to get for us for that. So we were able to get 8 iPads that were cellular capable, and we run into challenges with our network on putting them to use. But yeah, it's definitely been a challenge. Some of our newer providers, newer to IHS, concerns about providing services across state lines. But overall, our team is kind of looking at this. How do we turn this into an opportunity so we can rethink our approach to how we can optimize our system of care? I'll move that way. No, I'm done. I didn't just freeze.
No, that's great. Thank you so much. This has been amazing to hear what everybody's working on, as well as, in general, the parameters that everybody's working with, and how innovative folks have been regarding, and how quick, how fast. So people just turned this thing right around and jumped in. And it's been amazing to hear all of these suggestions and recommendations and kind of what folks are doing to respond to this. I want to open up this time now for discussion, and I just realized I forgot to introduce myself. I'm sorry. Jeff Crashway, Amy, Catherine Akia. My name is Catherine Akia, Yakama Nation member, and here today as a consultant for American Indian Health Commission to kind of launch this discussion part. And my colleague Jen Olson will also be helping out. Hey Jen, nice that your video is on.
Yes, and I also would like to open it up if there's any other tribal programs that would like to share their experience with telebehavioral health.
Yes, and in order to make this part of the discussion the most interactive possible via webinar, There's a couple of things I want to remind folks. You're welcome to put questions into the chat. I've actually got a Word document going, and I'm just cutting and pasting them all in there to try to make sure we hit all of the questions today, and any other questions that are not addressed today, that we'll make sure that we hit them up next week. Also, you're welcome to raise your hand. We'll get you unmuted. If you prefer talking, that works really well as well. We'll get that going as well. So we'll do the chat feature. You're always welcome to the raise hand. We'll unmute you. And then also the other thing could be to, to answer a few poll questions. So we're gonna get a couple of polls going just to get your fingers and your mouses going. And we'll have everybody answer the first poll question coming up in just a moment. And meanwhile, I am cutting and pasting a couple of the questions from the chat here. So first poll question to everybody. How long have you been offering telehealth services? So I kind of wanted to know, is anybody doing it ahead of time, as well as how long, you know, did folks jump in right as it happened? Or did some folks maybe wait a little bit while and then kick off their telehealth services? I'll give folks a few more minutes. While I'm letting the poll questions go, I wanted to let you know the 3 questions that I have seen so far. One I can answer right away. Will you be able to send a copy of the slides? Yes. As far as my understanding is that the center will have not only a recording of the webinar, but we'll have materials available as well. So we'll make sure that everybody gets those. The next question, this question came up during Dr. For's presentation, but I think really it would be great for all of the panelists, but Dr. For, I'll have you kick it off, and that is, can you provide recommended platform sites?
Right. Hello, everyone. This is Chris again. So the short answer is no. As a federal employee, I can't provide any recommendations for specific products. However, I can provide some general guidelines, and you all should know. So 2 things to note. One is IHS, right when this hit, we actually deployed our first nationwide telehealth platform that could reach into patients' home and was device agnostic, the Cisco meeting platform. This is open to anyone who has an IHS D1 account. So if you have that within your program, you can use this platform. The platform is good. It's not great. It's really set up for video meetings. So within that context, we are now doing market research. We've met with at least half a dozen vendors. We're meeting with 2 or 3 a week to try to see what's out there for a platform that we may want to use long term. So a couple of things that we are looking for that I would encourage you to look for in platforms. Usability. If it's not easy to use, providers won't use it. That's the bottom line. Security, for us, this is a big deal. So while HIPAA requirements have been waived, for us, we still fall under many, many other regs that have not been waived. So we've been very cautious about using other platforms. We can, but we've been cautious about it. The third thing I would think that you need to think about with your platform is how does it work in low bandwidth, high latency environments? We've heard everyone saying that connectivity is challenging in Indian country. You need a platform or software that I would say fails gracefully. When the bandwidth starts getting constrained, does it just cut all at once, or can you shift to a voice-only call? Those kinds of things are the things I would recommend that you look at. And lastly, again, right now you can use just about anything, but looking ahead, is it something that is HIPAA compliant or could become HIPAA compliant in the future? So I don't have specific recommendations, but those are the things that I suggest you look for in a video platform.
Really great recommendations. Thank you. Dr. Bellew or Melissa, are you, do you want to talk a little bit any about the platforms that are working for you? Where you might be headed?
Sure, and I have our psychiatrist, Dr. Vanna, here with me as well. We have been using the professional Zoom license since the beginning, and that's behavioral health and then also at the medical clinic. I don't know if you want to.
We've also been using Microsoft Teams, though, which is what the rest of the sort of Lummi Nation employees are using. And so especially when it comes to clinical conferences. Sometimes we use that addition to Zoom, but yeah, Zoom was something that we're able to adopt early. I also just want to put in a plug for Dr. Four as well. Dr. Four was very gracious to meet with the sort of Lummi Nation early in, I think it was October last year. Mm-hmm. And so it almost felt like we had a running head start when it came to COVID, because I think we were at least thinking about what some of these barriers may be, and he helped to sort of focus some of our discussion, as well as access some resources that are possible for Indian country. So I think we were very grateful, and that was going through my mind as I heard him talking earlier.
And for Camas Path, we are utilizing Zoom, but it's actually done through our electronic healthcare record system, and which is extremely convenient because it sends out the appointments automatically to the clients, and then it documents like who it was in attendance. So it does a lot of that self-tracking for us as well. We were fortunate that we transitioned to an electronic record system about 1.5 years ago.
Excellent, thank you. And Micah, did you want to read it, the platform that you're using that works the best?
Sure. We've been using the IHS platform Dr. Four referred to, and we were fortunate to get the cell phones given to us. But we've kind of primarily relied on telephonic, especially for the student outreach. So for any video stuff for our integrated behavioral health. But what we've found is, for the most part, our student-based stuff, the good old-fashioned telephone has worked the best and been the most reliable, especially for the youth on the other end.
Thank you so much for those recommendations. It's really helpful. I think hopefully everybody saw the poll results, but if not, it was 38%, 6 months over 6 months, and almost the majority of the rest in the last 2 to 6 months. So everybody, seems like everybody on this call so far, oh, thank you, 50%, has been doing telehealth for several months at least. Nobody's waited quite until now, so everybody's a little bit into this now, which is really great. And Kara, go ahead and launch the next poll for us.
Catherine, before, as we're doing that, I just wanted to mention, if for providers in Washington State, the Healthcare Authority did purchase a bulk amount of Zoom licenses, the HIPAA compliant version, that are available to any behavior health provider in Washington State. They are HIPAA compliant versions. Sometimes we've gotten questions like, I can't record my presentation, and that's because that function's not available. But we provide the Zoom licenses to SUD providers, medical providers, even prevention providers or recovery supports like certified peer counselors, prevention staff trying to meet with youth. So I'm going to put the link to the application. We still have those Zoom licenses available. I'll put that in the chat box, and I apologize, I should have put that in our presentation, but that is one resource that is available. And then just sharing about the work of the providing phones to folks in Washington State, to patients and clients. That was a partnership with the emergency management team that's in Washington State, and they typically worked with like the major phone providers to access some of those resources that we were able to get out to the communities. I know we're still trying to figure out how to continue that or add minutes to the phones that were purchased. So just something to think about for our state and for other states, those that are participating on the call. So I will put that in the chat box now. Thanks.
Thank you. I'm typing up some notes too to make sure when we put it out a Q&A after this, we'll capture that you still have healthcare authority still has some Zoom licenses available. That's really great news. Okay, so the next part next question that was put in the chat a little bit earlier was, though the same state licenses, some state licenses are not required, I've heard that many third-party payers are requiring them. So if somebody would like to address that, either Dr. Ford, if you'd like to address it kind of from a perspective across the nation, and then right after that, maybe Michael Longnecker, if you've got any kind of detailed piece on that.
Right. Hi, this is Chris again. We've run into this pre-COVID as well. It is a challenge. Let me give you a very quick example. 3 states in the U.S. allow psychologists to prescribe medications with additional training and licensure, New Mexico being one of those. So if my program hires a prescribing psychologist, they can prescribe anywhere in the country under the federal umbrella. However, that doesn't mean they're going to get reimbursed for those services. We have a prescribing psychologist in Wisconsin providing care within Wisconsin. Wisconsin says we'll reimburse you for your counseling, but we're not going to reimburse you for your prescribing. So this is not anything new necessarily. Although it seems like if you're within the scope that is similar, this is a weird one because psychologists don't normally prescribe, but if you're within a similar scope, it seems like it would be more likely for them to prescribe or to be able to reimburse. What we have done is we've made a habit of reaching out to the state CMS contact and by proxy third-party payers and trying to work that out with them, educating them as to why as a federal entity or tribal entity, things are different. So you might try that, but it can be a challenge.
Okay, and then I wanted to check in with Michael Longnecker on the statement that he put into the chat.
I'm really embarrassed on those slides I created. I was just listening. I thought, oh, I never talked about the IHS encounter rate, and that's probably one of the biggest questions. Remember those 3 types of bicycles, the bicycle, telemedicine. That's been eligible for the IHS encounter rate since we had a state plan amendment in 2018. But the telephone calls and the Skype, the tricycle and the unicycle, those previously did not qualify for the IHS encounter rate, but a state plan amendment went into effect, I tell you, 2 weeks after the pandemic started, and those do qualify for the encounter rate during the pandemic. I think I heard a question about third-party payers and requiring in-state licensing. I know that for Washington, Provider One, and the managed care organizations that we work with, we respect the out-of-state licensure for the docs that might be licensed out of state. I don't know about the third-party payers, though. If you have an issue with a third-party payer, let us know.
Thank you.
I think that's all I had.
Yes, no, thank you. Thank you so much, Mike. That's really helpful. And also, we'll take a look at our latest poll results. What are your long-term goals with telehealth? So it looks like we've got just continue using it, but move back into in-person, just a little bit with the app continue, and a hybrid. Okay, so almost everybody's looking at a hybrid model going forward. That's really great. Thank you. Thank you so much. And if you want to launch the next poll question, let's go ahead and launch the next poll question. Now, were there any raised hands out there? Did anybody want to unmute themselves and ask a question to one of the panelists? The next poll question is up on your screen, hopefully. If you have training needs around telehealth, how would you prefer to receive these trainings? And this is really helpful for all of our panelists on the phone, as well as the folks organizing this to really know what's the best way to get information out to everybody. Now I'm combing through the chats. I think I've got everybody, the 3 questions that were asked earlier. We have a question that just came in. While we're waiting for the poll results, we'll give the poll a moment and come back to the how to deliver telehealth training. The question to the panelists is, how long will telehealth be reimbursable at the encounter rate in Washington State?
'21st century, so many folks keep talking while they're still muted. I wish I had the answer to that. I being a computer person, I would like to give you an actual date. But the state plan amendment that allows the encounter rate for telehealth allows the encounter rate for telehealth during the governor declared state of emergency. When is that going to end? I don't know. We don't know. But just a reminder that telemedicine, the HIPAA compliant version, that was previously eligible for the IHS encounter rate.
You could update this slide with bicycle, still covered, unicycle.
I tell you, trying to do a billing webinar, I'm like, how do I get the difference? Because it's, in my dumb little brain, it's really simple. So I just came up with these bicycles.
I liked it. It was helpful for me. Thank you. Here we have from Deb Jonathan, just for information, Skokomis Tribe is launching a comprehensive primary and behavioral telemedicine health program on or before 11/1/20, funded by HRSA and CDC COVID grants. That would be one. Deb, do you mind if we unmute you and you could let us know a little bit about that? I don't have the unmuting thing, so if somebody else. Oh, computer mic isn't on. Okay, well, thank you so much. No worries. Thank you so much. Thank you for sharing that with us. That would be great to hear more about. And I think I was just talking to Jen Olson that somebody else might be on today who was also could give some updates on their program.
I had a nice chat with Cowlitz and also I think Squaxin Island, if anybody wants to share any information on lessons they've learned pivoting to telemedicine. And I would also, I hear Michael Longnecker, I hear you're saying that if we were to gear our tribal clinics towards telemedicine, that might be more reimbursable post the public health emergency. So as long as we all have an understanding of what is needed in place for telemedicine. Is that correct? And I'm sure we can share some documents on that.
That's correct, but what I've noticed is policy changes. Mm-hmm. So that's basically what I have to say. And telehealth may become encounter eligible 6 months from now, regardless of the pandemic. But at this time, the telephone calls and Skype are eligible for the encounter rate during the pandemic. But you're right, shifting towards the HIPAA compliant telemedicine in the long run, per the current rules, would maintain the IHS encounter rate.
Okay, sounds good. Oh, sorry. I should have chatted about it instead of said it. So Kara's asking me to close the poll. Yes, close the poll. Yes, that sounds good. Okay. So if you've got training needs, great. Okay, so 80% short 1 hour informational questions. Good to know. Good to know. And we're seeing a lot of information out there right now that people kind of zoom out. They're Zoom zoned out after about 70 minutes, right? You can't go much past an hour. Start zoning out on the Zoom. So that's really great to know. Thank you, everybody. Well, with that in mind, and because we just got a couple minutes and we are coming up on that time, any other questions for the panelists?
If you want to scroll to the second to the last slide while people are coming up with questions. One more and one more. So I just wanted to put this up here. This is a set of resources that are available to anyone in Washington State to call. It's sort of a telehealth program in that providers can call any of these lines to have case discussions with a psychiatrist for, assistance in helping to manage a particularly challenging case or something like that. And so we have the psychiatry consultation line, PCL, which is for prescribing providers with adult psychiatry or addictions questions. There's the partnership access line, which is basically the same thing, but for patients who are children or adolescents. And then we have the PAL for Moms line, which is for providers, not necessarily prescribing providers. That's the one line that you don't have to be a prescriber to call. And you can talk to a psychiatrist about behavioral health questions related to pregnancy and postpartum patients. And then also every Thursday, it actually is just going on right now, we have the Psychiatry and Addictions Case Conference Series. It's an ECHO program, if you're familiar with that, where we have a didactic every week followed by case presentations and discussions. So all of these are free services to anybody in the state of Washington, and you're more than welcome to join to any of those.
Great, thank you. And I just wanted to reiterate that what we'll do is we'll draw up, I've been taking some notes, both from Lummi and Calico's presentations regarding the innovations and the barriers. So there are some barriers that still, I think that, I don't know if anybody's figured out a perfect solution, but lots of folks have got some good workarounds. So we'll draft those up and pull those together so that next week when we're discussing a little bit more going into, well, what are some of the solutions that people are finding that are working? We can keep going with that, and just really appreciate sharing today on what's been working.
Right. Last slide, please.